taking the time to join us for this PQMD Pillar Talk webinar, a part of a larger series of webinars which the PQMD community of practice cultivates to address major trends, leading thinking, best practices, provocative issues in global health. We also host a series of webinars focused on timely issues related to COVID-19, which is generously supported by Pfizer. More information about this series is posted on our website, which we will note in the chat box. Please join us for this incredible series where we will highlight major actors and explore issues, including the forces of health security, vaccines, trends affecting supply chains, and therapeutics. PQMD is able to put these webinars together because of the strength of our coalition and the depth of our work, the work of our members, and the work that they do every day. We have been very fortunate to have the participation of some very high-level and knowledgeable people, and we look forward to you joining the discussion too. I'm Elizabeth Ashbourne. I'm the Executive Director at PQMD, and I wanted to welcome you together with our entire team. PQMD is a global alliance of international NGOs and leading healthcare companies committed to advancing the role of quality product donations worldwide. We have 41 members, and we are celebrating our 20th anniversary this year. Our work is guided by 5 pillars: humanitarian assistance, health system strengthening, disaster response, preparedness, guidelines, and knowledge management. Today, we are going to focus on our medical missions work, which many of our members support through services, products, and funding. We have developed a set of clear and concise guidelines which are posted on our website to make sure that countries are in the driver's seat when it comes to urgent and valuable support to their health systems. We have vetted the guidelines in Malawi, the Philippines, and Honduras, which you will hear more about today, to ensure that local organizations and ministries of health have the tools necessary to guide assistance and make sure that interventions have a sustainable impact. Clearly, COVID-19 has disrupted how medical missions can meet specialty and primary clinical needs around the world, especially because the work depends largely on international travel. Yet we also know that medical mission work remains an important resource for tertiary and primary health facilities around the world. You'll hear today how our work is currently informing action and programs even in the midst of this pandemic. Furthermore, as groups pause their clinical activities at this time, we know our guidelines and checklists will continue to be an informed source of best practices when they are ready to resume international medical missions trips. Also, just let me mention that it is Guidelines Week this week, where we celebrate the use and reach of guidelines for quality medical donations, but also for medical missions. Please check out information on our website and on our social media platforms so you can be part of the celebration. So let's get started. But very quickly, I wanted to review some housekeeping rules. So please go ahead, warm up your fingers. Please type your name in the chat box and let us know your organization. And because of the size of the audience, all participant microphones are muted and their microphones and videos disabled for this presentation. We do invite you to use the chat box to direct any questions and comments to our panelists, or there will also be time at the end of the group discussion, and we'll be monitoring the chat box so that we will be able to hopefully interject some of your thoughts and questions into the dialogue. I will share the link for PQMD's online community of practice also in the chat box. And lastly, we are recording this session and it will be available afterwards for your review. Now I have the pleasure of turning it over to our fantastic speakers and the moderator for this session, Julie Marie Vanderberg. Julie Marie?
Thanks, EJ. My name is Julie Marie Vanderberg, thanks, and I support the PQMD team as the Senior Director for Global Health Programs Policy. I am so thrilled to be moderating this panel today, not only because of the quality of the work that you'll be hearing about and the professionalism of our 4 panelists, but also because I've actually dedicated over a decade of my own career to short-term medical missions work. I'm so fortunate to have worked kind of all sides of this unique and important model of clinical care. And seeing who's here today in the chat box, I know no doubt that we all understand the value of providing services in this way, yet we also clearly see the potential real shortfalls that can arise if short-term medical missions aren't properly managed. So PQMD is so excited to lead with these clear guidelines. And also we want to ensure you that we're looking to deepen this work in the future, make it stronger and better with your help and your insight. So we wanted to start off with 2 questions that possibly you could type your answers in the chat box, either immediately or as you're thinking of things along the presentation. I'll put them in the chat box as soon as I'm done here. But the first one, we wanted to ask kind of about which areas do you currently feel really good about the data that you're collecting related to your medical missions work? I imagine that this could be, you know, sort of, you could talk about needs assessment or patient outcomes, community satisfaction, or volunteer performance. You tell us. And then the next area we wanted to look at was potentially, where do you guys think that you'd like to collect more information or data that would really improve your programming? Again, you know best, but perhaps you're thinking about the ever-changing nature of importation requirements or longer-term feedback from patients or follow-up from clinicians. Maybe it's facility satisfaction or how your donations are utilized throughout the year. But we do want to hear from you. So please let us know. And we're going to address these at the end of the discussion with our panelists. We'll have hopefully have a robust discussion with you. And I just wanted to reiterate, if you have any questions at any time, we won't stop the presentation, but if you type them in the chat box, you don't have to remember them. I can call it out at the end of the session. And with that, I would like to ask our 4 panelists to introduce themselves, starting with my dear friend and colleague, Julie Varughese.
Thanks, Julie Marie. Good morning, everyone. Just wanted to start by saying thank you to PQMD for convening this discussion, and also just for the tremendous partnership that PQMD and my fellow co-panelists have provided on this project. So I'm Julie Varughese. I'm the Chief Medical Officer at Americares. My background is that I'm an infectious disease physician and have been on many short-term medical missions myself. So really have a personal and professional interest in this area. Thanks.
Good morning, my name is Patti Tracey, and I'm a registered nurse and a global health researcher. I've been a member of the PQMD working group since its inception, and I was the lead researcher on the 3-country study and doing the feasibility work in Honduras. I hold a full-time faculty position with the Trent School of Nursing in Ontario, Canada, and I have led and participated in short-term medical missions for over 15 years. I stopped counting at 15 years because I couldn't remember anymore at that point. Currently, though, biannually, our school participates in community development international placements to Honduras alongside our partners in Tegucigalpa. And this fall, we'll be doing our work virtually. So thank you.
Morning, everybody. I'm David Venegas. I've been working for this project in PQMD for the past years. I work for international NGO. I'm a national director for Irish Aid, and I've been working for over 10 years in that institution. I'm a journalist, and I also help with the logistics with the Trent University when they come with a short-term medical missions in Honduras.
Good morning, everyone. My name is Patti Wagner, and I'm the Medical Operations Coordinator for Friends of Barnabas in Richmond, Virginia. I, too, am a registered nurse. I've been on the staff of Friends of Barnabas for the last 6 years, but have been a volunteer and led medical mission teams for them for the past 19 years. Friends of Barnabas is thrilled to be a part of this project and hope to continue to move forward with this.
Right. I'm going to share my screen briefly with everyone. Okay. Everyone can see my screen okay? Just a quick nod. Awesome. All right, so just again, thank you everyone for participating on this webinar. We're really excited as a group to be here, and just wanted to give you an idea of an overview of what we're going to be discussing as a panel, and then really looking forward to discussing with all of you just some of the challenges that you all face in terms of your short-term medical missions practices, and certainly the impacts that you're feeling from COVID. So we're going to start with just a little bit of background as to what led to this work and the development of the guidelines, followed by some high-level findings from our quality improvement work in each of the 3 countries that we conducted outreach in, followed by just what some of the challenges are in Honduras in terms of broader implementation and feasibility around that. And then Patti Wagner is going to close out the discussion with some realistic perspectives in terms of how one of our international NGO partners has utilized these resources and then identified their own strengths and opportunities for change. So short-term medical missions, or really short-term any kind of global health experience, helpful or harmful? I think this is a very highly debated issue and is really a complex issue. Every year there are thousands of teams that travel from high-income countries to low and middle-income countries to provide clinical care, surgical care, medical care, and really with good intentions. But certainly one can make the argument that there's a question around who really benefits and what are those benefits exactly. I think that when missions are done really thoughtfully and strategically and with really strong bidirectional partnerships, there can be a lot of good that comes out of these kinds of efforts for both sides. But oftentimes, if that isn't the case, there can be harm that's done. And the clinical care that's provided can be done in silos apart from the local health system, and there can be a lack of sustainability. So it's really great to have everyone talk about this important topic. So just to give everyone an idea, the Health System Strengthening Medical Mission Initiative started 4 years ago, actually, and it's really been a collaborative effort to understand the current practices around short-term missions and then work together to identify ways that we can better strengthen this practice. And what we found is that a lot of the existing guidelines didn't have as much of a field voice as we would have liked to see. And so working with colleagues from PQMD as well as other colleagues from NGOs and academic institutions, we really sought out feedback from international stakeholders. We worked with colleagues from Honduras, the Philippines, Malawi, to see how they felt about current practices and what they would then like to see in terms of short-term medical missions. And so we were able to really reach a broad range of stakeholders, doctors, nurses, other clinical professionals, as well as government officials, community leaders, and others that are involved in the practice of short-term medical missions. So based on the feedback that we received from both our domestic as well as international colleagues and following an extensive literature review, we landed on 9 key areas that we really felt were important when thinking about best practices for short-term medical missions. I'm going to quickly just read through them, but assessment, partnership, governance, code of conduct, preparation, implementation, training and capacity building, sustainability, monitoring and evaluation. And as you can imagine, there's a lot that goes under each of these categories. What we did is identified a lot of the different components that fall under these 9 categories, and then developed a side-by-side set of guidelines or best practices, both for the sending organization as well as the host organization. And you can see here just a small example of the different kind of components and then the side-by-side comparison. And so as you can imagine, there's a lot of information that comes under each of these 9 categories. We got to some 20 pages or so in terms of the set of guidelines. And so we really see it as more of a reference document. Based on the feedback that we received from our international colleagues, they identified the need for more user-friendly, shorter checklists that could be used as a supplementary resource. And so I think it will be helpful to kind of go through these 9 categories by utilizing one of the checklists. And so I'm going to take you through the checklist for a sending organization, as I think many of the participants on the call are more on the sending organization side. So just to quickly give you a quick rundown. On the pre-departure side, there's quite a lot that sending organizations should really think about. So when you think about assessment, it's not just the clinical assessment in terms of what the local community may need from a health perspective. There's also a lot that needs to be done in terms of resource assessment, both from the sending team as well as the host team. what's needed in terms of logistics and accommodations and other health or non-health aspects. There's also a cultural assessment, really understanding the local context in terms of culture and how that then impacts the health system and the way that clinical services should be provided. The second broad category is partnership. And I really can't emphasize this enough in terms of that importance of partnership and really understanding each other's organizations, your strengths, your challenges, your needs. And I really highlight needs on both sides. Oftentimes we think about the volunteers coming and meeting a need for the local community, but I think there's also need for the team that's coming too, and what they may learn and gain from the experience. And so really being clear about what the expectations are and what each team hopes to gain. Governance is the third category. This is often very loosely approached, but certainly is very important. So thinking, what are the rules, the regulations for each organization, but also locally, what are the standards that are needed for practice in that country? So thinking about a scope of work for every single individual that's on the team, what is outside of that scope of work? So especially thinking about students and trainees, certainly in the home country, there may be restrictions. And there are times where these trips are viewed as an opportunity to practice medicine a little bit more liberally, I'll say. And really, we want to stay within the scope of work that one would expect in their home country, unless certainly regulations are different where they're practicing locally. The fourth area is code of conduct. So again, just being very clear about what are the expectations in terms of behavior for volunteers and host staff members, both in the professional setting, but also when you're off hours, being really clear about what is expected within that context. The fifth category is preparation, which I think is pretty clear, but just want to highlight again, it's not just preparation for the clinical services that are being implemented. There's a lot that needs to be thought about with regards to the volunteers, their health requirements, safety, security, and again, those cultural pieces that are so important to have training and background on prior to the trip. So those are some elements, before a team even leaves that need to be prepared and organized. And then there's everything that happens in country with implementation of the work. And so again, setting ground rules on communication, frequency of communication, types of communication, reporting, and again, thinking about roles and responsibilities and continuity of care, I think is a really big one. Just understanding and utilizing the local healthcare system appropriately in terms of referral pathways and ongoing follow-up that's needed. Also, a big area that we really wanted to emphasize is training and capacity building. So these trips are not only an opportunity for clinical care to be provided, but it's also an opportunity for training, capacity building, mutual learning between the host organization and the sending organization. And so it's great to build in those pieces. And I think a lot of teams are increasingly consistently building in a training piece into their trips. And so once all of the pre-departure and the implementation takes place, there's also a lot that continues after the team leaves the country. So thinking about what is the ongoing communication going to be once the team leaves country, what kind of follow-up or telehealth services might be provided, and thinking more long-term, just going back to that partnership, how can you then build out more sustainable impact and sustainable practices, exploring other partnerships that may be helpful to that role. And then finally, the ninth category is monitoring and evaluation. So oftentimes we think about output type or activity level evaluation, so number of patients seen or number of surgeries performed. But what are some of those other metrics that we want to look at to really measure success? So Julie Marie mentioned some of them, is it volunteer satisfaction? Is it satisfaction level of the health facilities? Is it health outcomes in the community and aligning with overall national strategic objectives for health? So I think there's a lot to think about building out more in the monitoring and evaluation space when it comes to short-term medical missions as well. So that was a very quick rundown. Certainly there's a lot more detail in both the checklist and the guidelines that you can find on the PQMD website. And so there's a whole toolkit of supporting resources that you can find, and the website is listed there, and I think it's been shared in the chat. We're also really fortunate in terms of some next steps that the PQMD Guidelines Committee has formally adopted these medical missions guidelines. So certainly PQMD as a leader in donations guidelines, to have their support on the medical missions guidelines has been really fantastic. And so the Guidelines Committee will be doing an annual review, and will also be leveraging ongoing engagement from our working group volunteers to review the guidelines and update them. So in addition, we're also continuing to find ways to disseminate this information, continue to advocate for this important topic, and just really raise awareness on both the importance of short-term medical missions, but also some of the challenges that are associated with that. So with that, I will turn it over to Patti Tracey to share a little bit more about our quality improvement work in each of the 3 countries that we were working in.
Okay. Thank you, Julie. So Honduras, Malawi, and the Philippines were selected as the sites for this research project, given their high volume of short-term medical missions. And these countries host healthcare providers from the top 4 sending countries within the world, and that's the United States, Canada, Australia, and the United Kingdom. The in-country research trips provided both an opportunity to evaluate the draft, that larger draft guidelines document, but then also the participants participated in an interview or a focus group. So this was a convenient sample, and it was quite representative of all 3 countries. Julie mentioned who our stakeholder group was, so I won't repeat that here. As you can see, there were a total of 118 assessments, and the breakdown is provided for you in the slide between the different countries. We conducted the research in both urban and rural settings, and just so that you understand, 95% of the participants were living and working full-time in their representative host country. So there really was an attempt with this initiative to favor host country input, because that really is what tends to be lacking both in existing best practice guidelines, and there's also quite a gap in the literature around perspectives of hosts. Next slide. So overall, the participants expressed a strong interest and desire to have more structured guidance surrounding medical mission practices. And there was really a very positive response to the proposed practice guidelines that had been presented. These guidelines have been updated twice, both since this research began and from the great feedback we had from the Guidelines Committee at PQMD. The table you're looking at provides you a summary of some of the key highlights from all of the interviews that were done in the 3 different countries. There definitely was a difference between the dominant practices of sending staff and the preferences or perspectives of host staff in the 5 key areas. And we listed the 5 key themes or areas along the left-hand column of this slide. I'm going to just draw your attention to 2 areas that I think were big lessons learned for us within this study, and that's both the primary objective of the trip and the practice within scope. So the primary objective of the trip for sending staff, they would say that the primary objective is direct provision of clinical care or patient care. And then the host staff would indicate their primary objective for the trip would be a need for capacity building, and then a more dire need for improved access to needed medicines, products, or supplies. And as part of the interview, we also asked the sending staff to identify during their whole trip, so often these trips last 7 to 10 days, maybe a bit longer or a bit shorter, what percentage of work was clinical care, what was education, what was transportation or travel within country, cultural learning, that kind of thing. And in actual fact, only 25 to 30% of the medical mission was direct patient care. And then the next one I wanted to just speak about briefly was the practice within scope. this really was learning for us, and we heard this from all 3 country participants, that the practice differed. So sending staff spoke of this loosely or undefined practices for primary care physicians and trainees, whereas the host staff wanted clear parameters around the practice within scope for all providers. And specifically, medical students were raised. You'll note when you have a look at our guidelines that you'll see that we did add that the importance of clinical supervision must be adequate. And then Julie mentioned the pre-trip preparation, and that was definitely a very clear theme throughout the research, the importance of that. So the next slide. Some general takeaways. There were many, but we've tried to sort of consolidate them here in these points. Just to reiterate that there was overall agreement that all volunteers should strive to be ethically and optimally contribute to locally led efforts. The title of this project was around strengthening health services within these countries. So that's very much was important, and it needed to, the groups should be supporting locally led efforts. And there was a call for better coordination between the sending and the host participants. And this should begin a minimum of 6 months before a trip, but commonly pre-departure planning begins almost 12 months before the trip would happen. And then, as you'll hear from some of, Patty's going to speak about Friends of Barnabas and others, we definitely, groups have a sustainable project, so they sort of have continued supports to the organizations and agencies, so that does vary. There was a focus on the fact that geographically, short-term medical missions should consider more hard to reach or remote regions. Medicines remain this critical priority and a needed resource. And interestingly, medicines and technologies and products can often be a driving force to begin potential engagement with foreign medical missions. Consistently, the participants discussed the disconnect between identified local needs and government level supplies, products, and medicines procurement, especially in the more rural or hard to reach clinics. In fact, in both Malawi and Honduras, multiple informants in the study shared how quality of care is routinely compromised given the consistent lack of medicines and medical supplies. And medical teams could play a role in this to help support some product need. However, it's important, I think, that we remember that there's differences in local formularies, and the familiarity with medicines and treatment protocols need to be accounted for. Lastly, and I think probably most importantly, we could have put this at the top, but the importance of the in-country staff and support is critical. This definitely helps with that information around formularies or local practices, and also around understanding cultural awareness and difference. And though we are advocating for international acceptance of best practices throughout the world relating to short-term medical missions, we do acknowledge that context will vary, and you will have differences within country from one setting to the next. And with that, I'll stop there, and I'm going to pass it over to David, who's going to speak more specifically about work within Honduras and the feasibility study.
Thank you, Patti. Okay, for you to have a sense of Honduras, we wrote down that try to explain what's and how Honduras looks. Honduras is as big as Tennessee in the United States or as in British Columbia. So at that point, you have to know that we have 2 major airports in our country in 2 different regions, one in the north and one in the center. So it makes easier for short medical teams to come to the country and get into all of our area. So if you come here, you get to rural areas, you get to the city, and it's easy for you to come and work. Our population is not that large. We have 9 million, and we have ease of travel. So for us, working on the PQMD project, we found lots of things that we've done. for example, we've been having interviews, we have lots of feedback. We had the resources, and also we know that people want to work with a PQMD. Everyone is wanting to get in the scope of practice. They want to use the guidelines. We've been working with a large group of persons in Honduras, and all we get is it's great resource. They want to strengthen their system, the health system with Honduras, and what we want, and with what they do. Also a checklist, the essentials, pre-departures, and all the work we're doing with the sending organization, all the follow-up, the in-country and post-mission that we've had, makes us think that this is a great work that we've been pulling together and doing it. So what we have in here is that, and it's estimated that the 60% of the population are covered in our health care. 10% of they have workers, health benefits, and other 10s they pay for it to have it privately. So this leaves a 20% of the population without. Most among the 53% of Hondurans live in rural regions, so it's hard for them to have an access to healthcare. And these short medical missions, they provide the health that these people need. So it's us, by these services, who gives us this access. So in Honduras, and we have lots of missions. We had a calendar in 2012 that reported an average from 28 to 40 international monthly short-term medical missions. And the Ministry of Health, from that medical missions, they capture the 50% of those medical missions, but only if they're surgical missions. On the next slide, this is what we've been working on, the pilot testing in Honduras, and the goals. And the goal is to understand the feasibility and use of the guidelines, documents, and also the companion host and send-in checklists. Following that key, informant interviews from the 3 countries that have been done. Honduras has done the same, and also we've had over 20 participants. We have hospitals, university, local NGOs, and for us it has been a great resource to work with them. We have been working, for example, in a hospital in the south area of the country, in a hospital in San Lorenzo. We've been trying to develop with them because they had already a checklist, and now they've been using what we've shared with them, the documents, the guidelines, and also the checklist, because for them it's a way to see and well, I'm nervous, I'm sorry. So I'm nervous. So for us, it's been a great, for them, it's been a great resource. That's why they've been telling us. They didn't have anything. What we've done is provide these hospitals, these universities, and these other NGOs more information, documents, research, and a way to do things better in our country. So all the 70+ interviews we've done, all the people that have been working in Honduras, and all the over 118 people who work around the world, they need the PQMD. That's what I can say as my personal opinion. It's not only a checklist, a guideline. I know it's lots of work. We don't have it. we didn't have it in Honduras. Now, we, as a host organization, we said we can tell that the guidelines do help with future evaluations, with unknown evaluations, and also the checklist makes easier for everybody. And so now Patti Wagner can tell us more about her organization and her work in Honduras.
Thank you, David. So Friends of Barnabas is a small nonprofit organization that serves 30 remote mountain communities in 4 departments or states around the Lago de Yohoa area of central Honduras. We've been serving there for the past 20 years. We have 3 main programming areas: community health development, which provides health promotion and prevention education, as well as primary care clinics with our medical teams. Our extended care program, which provides case management for close to 300 children throughout Honduras who have long-term medical needs that would otherwise be unmet. And our early childhood development program, which provides education for community leaders, parents, and medical professionals on topics related to early childhood development. Our current project in the early childhood development program is specifically with the neonatal intensive care units and nurses in San Pedro Sula in trying to increase their standard of care and standardize that across the board. Next slide, please. Friends of Barnabas has always taken pride in the fact that we strive to do our work with sustainability as our goal and best practices as our guide to care. This is an ongoing process, as it is with all of us. We have used the PQMD guidelines as a quality improvement tool. I'm very proud to say that as an organization, Friends of Barnabas was already meeting most of these guidelines when they were first presented to us. So the first area of improvement that the PQMD guidelines highlighted for us was how our services could be better tailored to the individual communities we serve. Historically, we had taken our set of health education programming and presented it to each community over a 3-year period of time. We're now taking steps to meet the requests or the identified needs that are voiced by the community members during their initial community assessment, or those needs that are identified from the data we collect. We're also making a greater effort to connect our communities with other nonprofit organizations that can meet their identified needs that don't fall within our programming area. Under the area of clear scope of practice, we have been relying on our team leaders to prepare and train our teams for their mission week. We do a team leader training, provide them with an extensive team leader handbook, as well as providing each team member with a team member handbook. This has not been as effective as we would like. We are presently in discussion with an e-learning company that designs learning modules that each team member would be required to complete prior to their trip. These modules would walk the team member through all the topics our organization sees as essential to preparing for or working in their week of clinics. We can track who does the modules and how they score on post-tests. We feel that this will help make our team preparations more consistent and thorough, as well as being a fun activity. Patient and participation cultural safety is also an area that our organization knew we needed to improve upon. Our team members haven't been culturally insensitive for the most part, but there were multiple areas where we knew we just needed to do a better job of increasing cultural awareness. In our new team training modules, we'll have plans to more directly address cultural awareness topics. We've always stressed a model of servanthood, and we also stress privacy issues, especially around social media use and the sharing of case stories while in clinic. One specific way we're addressing cultural norms in our medical clinics is providing resources on more commonly used natural remedies that the community members would be familiar with, and would also provide and be effective in treating certain health-related issues. We know that the supply of medications that we provide in our medical clinics don't always last that 6 months in between our visits to the community. So teaching these treatment options is essential. The biggest challenge that we've had in the area is in the area of data collection, and one that is not uncommon, I'm sure, in most short-term medical mission teams. We've been documenting patient visits on a paper trifold card for the past several years. And data from these cards is collected at the end of the year, but it tends to be numbers focused and not outcome focused. There was no way to store information on thousands of patient cards from year to year, so data got lost. Earlier this year, a generous donor group purchased the equipment and a year's subscription to Backpack EMR for our use. We will now be able to collect and store data from both our medical team clinics as well as our standalone clinic in Peña Blanca. We're extremely excited to get this off the ground. This EMR will allow us to track patients, follow up on referrals that were made, as well as collect and store important data points. And finally, in the area of post-mission follow-up, reporting our work and referrals to the local health clinics is one thing we've not been doing. We really needed to make a greater effort towards information sharing. We have built a wonderful working relationship with the Deputy Minister of Health for the Department of Cortez, which we feel will give us more opportunities to find the best way to support the work of the local clinics, as well as communicate to them what our clinics have found to be issues in their respective areas. This would be more for the referrals for our adult patients. Our extended care program cares for and supports the children who are referred for further follow-up. Friends of Barnabas fully supports the efforts to standardize medical mission team development and implementation. Safety should be the utmost concern, and medical mission teams should have a standard of care and practice guidelines to follow. This, of course, all depends on the willingness of the respective country's health ministry to make it a priority. Education of teams from the participants' end can and should be done with the PQMD standards being the guiding tool. Friends of Barnabas is happy and willing to be a resource and support in these ongoing efforts. Next slide, please. Our biggest concern at present, as with most of us, is when and how we'll be able to get our teams back into the country. There are multiple milestones that must be reached before we can even begin to think about sending teams back to Honduras. Opening the borders both in Honduras and the U.S. is one, available air travel into the country, and most of all, the lifting of quarantine restrictions for both Honduras and the U.S. So as a panel, we're really interested in hearing from you and your organizations concerning your plans or the discussions that you're having about the changes that may need to be made before restarting your medical mission teams. And with that, I will turn it back over.
And Julie Marie, before we turn it over to you and open up the discussion, and really looking forward to hearing about how everyone's adapted to COVID and share our thoughts too, just wanted to close this slideshow before I exit out by again saying that this really has been a collaborative effort, and we've had the support of so many people from our working group, PQMD, Trent University. So many people have been involved with this effort, and so we just wanted to highlight that again and just say a huge thank you, and looking forward to opening up for discussion. So I'm going to stop sharing my screen and turn it back over to you, Julie Marie. Thanks.
Sounds great. Thank you all for the fantastic presentation. And I just wanted to echo that as well. There are lots of people who aren't on this video today who have had a major role in this project. And so some of who are on the line today too. So we definitely wanted to share in the success of this, and also kind of now's the time to open up for questions for our panelists or for each other. I think, Jen, we have everybody, we can unmute everybody. So if you have something you'd like to share, let's just kind of talk about first question about our medical mission and from COVID-19, and then we'll go from there. Just take a quick pause to make sure that our participants can talk. I see Jen's at work, unmuting everybody. Or you can raise your hand if you'd like, and we can go ahead and unmute you. Anybody want to take a first? Has been doing during the pause, maybe, or some of the things you've been thinking about, how you're going to pivot or change some of the work you're doing, or potentially even explain how maybe local teams are still working, or if any of the equipment that has been used for maybe COVID response. That might be interesting to hear too.
While we're waiting for people to jump on, Friends of Barnabas, our staff in Honduras, of which we have 20, has been extremely active during this time. They discovered very quickly that they could use WhatsApp to send videos and educational materials. So they weekly have been sending either a video with a pertinent piece of information about COVID or treatments or things to watch for, along with all kinds of things about early childhood development. That has gone to all of our communities, actually, all our community leaders, of which there are probably 30 right now that, well, I think there's 50 that are getting them, plus all of our extended care families, which is over 300 families. So that's been one way that we have actively been continuing our work. The biggest challenge has been getting medicine down there, which we've actually now found the loophole and gotten our first shipment down. So we're super excited about that.
Come on, congratulations. And that's really exciting to hear that you found kind of very meaningful ways to stay present. Actually, that kind of, well, you know, it's sometimes easier to send your messages in by the chat box too. And that message of WhatsApp really reminds me of something that I'd been thinking about too. It's really great to hear about the willingness to improve and use electronic resources for training and for data collection. Juxtapose, I heard kind of in your presentation too about the challenges of information sharing, both you know, in terms of patient privacy rights and coordinating data collection points with what's kind of prioritized for local groups, and then potentially even a shared analysis plan to better understand what maybe you don't see behind the scenes. I'm just wondering if you're finding, maybe David and Patti, you could help, or Julie, anybody who's running missions could also maybe linger a little bit on, are you finding that data is also being leveraged directly with patients?
I know for us, we actually, with our extended care program, which actually what comes out of our medical teams, have done some quality improvement projects with our staff following the Six Sigma project model, specifically around nutrition and weight gain in our cardiac kids. So that has been new for us in the past 2 to 3 years, but the data I've collected, we utilized to do a lot of that, but the staff developed those projects and has implemented them, and we have made major improvements in all areas there. So that's been really exciting to be a part of.
And I see some of my old colleagues from Operation Smile online too. I'm going to call you all out there. Pat, I see
I
Lisa,
knew you were going to say something.
Janina, come on, join the conversation.
You know, it's interesting. I was just thinking of, I was on a call this morning with India, and you know, so all of our missions have been impacted, of course, because of COVID. And we are looking at really different innovative ways of still supporting our work. And I was listening to our colleagues in India, and they were talking about this has really given them an opportunity to look at data and assessing all the patients in a different way and collecting different data and looking at that complete care. And they were identifying a lot of the patients, not a lot, but patients that needed speech therapy, and how they're looking at including that during this time. We've been doing a lot of work virtually with patients. And so there are patients that still need help speaking. And so we've been able to have speech therapists on, virtually on the laptop with a patient. So we've been looking at different things. They're doing different type of works around nutrition as well to ensure that some of the patients that still need the cleft surgery will be able to get that surgery once we're up and running again, but by providing them with nutrition so that their weight is at the level it needs to be for us to have to be able to work on them. So that's like a few things that we're doing, which I think is pretty interesting. And I don't know, Janina, if she's on the phone, I don't know if she is, but she may have something to add to that.
I'm just trying to give her a minute in case that she's muted. And
It looks like she raised her hand, Julie Marie.
oh, okay. And Giannina, I'm trying.
I knew you were going to call on me though.
How do I unmute myself?
Okay, I'm trying.
Jen, are you?
I'm trying to. Yep.
Okay.
Yep.
Sorry, Giannina. Let's just give us a minute.
She's able to.
Okay, so we see that you're able to.
Hi, so good to
Hi.
see you, Julie Marie.
Yeah, I know you do.
Well, yes, all of our countries have been working. It has actually been interesting to see patients that are saying, you know what, for us it's cheaper to do speech therapy on the phone now that we don't have to travel. So in a way, it's been an eye-opener for us on a way that we can do things even if we're far apart, and how that can even be better for the patients that we're treating. And that's something that we honestly didn't think about before. So it has been an eye-opener, and nutrition has been a great piece. We have been, I've been more involved with Latin America, and I can tell you all the nutrition that we have been able to get new donors to be interested and sponsor those specific projects that we weren't doing at the time. So we're doing more dental. We have put as a priority the nutrition part, and even we have been doing consultations and all of that in very, obviously not in the regular scale, but doing it not only in missions, since we were not able to do it, but at the centers where we provide integral care, so speech therapy, dental, mostly for babies, because they're the urgency. They're the ones that could die if we don't treat them on time. So it has been, I think it has been eye-opening for the whole organization.
Yes, it's fascinating. I think, kind of recognizing the silver lining or the opportunity to kind of look and dig into what mission groups who are typically only, present in country for a set amount of time might be able to do with sort of continued patient care through virtual components, or potentially leveraging more local resources. So thank you for sharing that, Giannina. Does anybody else have anything they'd like to share?
Just to echo kind of what others have said, I think the pandemic has really just forced so many of us to just rethink some of those old ways that we were practicing, and to really think creatively, and also look at, Julie Marie, to your point, kind of what's actually working well and could be continued in a post-pandemic world, right? That maybe we don't have to just revert back to the old way of doing, because it actually makes more sense to do some aspects of our care in leveraging technology. So just thinking about that silver lining and what changes or like what hybrid might be created post-pandemic when we all come out of this.
Yeah, and that would be a fascinating thing to work on, kind of together with this group as well. It's maybe a challenge to put forward. That also brings me to something else that came in during the conversation, is that, well, first of all, I just kind of wanted to echo, thank you for ensuring within this work that the host country voice was so highly elevated. I think that's one of the most valuable pieces about the methodology of this work, and obviously the findings. But we wondered if you could speak a little bit to kind of what kernels of wisdom that the host country group kind of as a whole collectively may have shared about if, and then if, how short-term medical missions can really be leveraged for longer-term health system strengthening work.
I'll start. I'll just make one or 2 points. I think they very much talked about the fact that the guidelines and having this sort of best practice resource allowed them to have some of maybe the more difficult conversations that they need to have with sending organizations. So whereas they could point to the guidelines and say, well, you know, this is best practice, maybe we should look at doing a memorandum of understanding, say, for example. You know, we need to have a needs assessment done before the trip. We need to talk about how follow-up care is going to be done, how the patients who require follow-up are going to get back into the public healthcare system. You know, what does that look like? So I think that was definitely one point that came forward quite clearly from all of the countries, that it allowed them a resource to say and to have some of those harder conversations.
Yeah, that's really great. And then did anybody else want to add to that?
I would just add to just really an emphasis on staying connected with kind of ministries of health, both from a priorities perspective, but also from a parameters and regulations perspective, that, you know, even if the two partners were aligned, that you really want to go up the next level to make sure that the missions are linked. And, you know, I think that's so important. And that did come through as well in terms of some of the feedback that we received from each of the three countries. Because to Patty's point earlier, every country is very different in terms of context and what they already have in place. And so really trying to just reiterate some of those pieces is important, both on the sending and host side.
Mm-hmm. Great, thank you. And we have time for probably just one more quick question, which came in, and maybe we can look at it from a host perspective. I don't know if, David, you might have some insight here, but one of the participants wanted to know, Christine Lafferty wanted to know, how much are sending organizations working with partners who do sort of public health work in the country, as well as, you know, not just the clinical and medical services, but how do they link into some of the on-the-ground public health work?
I'll start, and then David, you can chime in. It's a great question. I had done medical missions for many years, and I really, maybe it was part of my nursing perspective or the lens in which I bring to health outcomes and the health of people. But I started to become quite concerned about the fact that we weren't getting to the root cause of the problem. So we weren't looking at the overall social determinants of health, the things that make people well and live longer. We could keep giving medicines and pills for parasites, but yet we weren't working on clean water projects. So I actually switched when I finished my doctoral studies and started doing more focus on community development. So, you know, but I did that for many years because I do think there's still a need, but it needs to link with the local and regional health center. But I have switched our groups now to more public health, health promotion, and health prevention for Trent University. No, David, if you want to add. And
over that, this is a conversation that we have all the time with Patti, what we need to change on our short medical missions, right? Because what we have in our country is we're just getting, as Patti said, pills. We're not going to the focus, what people needs. So over the years working with Patti, knowing villages, knowing more people, now I know that our impact in these villages and in these communities, this is really working. It's a sustainable project. People wants to know more, they want to participate, and also they are expecting us to be there and keep working because they know that we're constant. And not only constant, we do help people not only coming twice a year. It's a all year round having them, you say post-medical medical brigade. What we have is an all-year communication. We always know what's happening with the communities. We are in constant communication with community leaders, and we're trying to work for our next group to come and do better every time.
But the group
Yeah.
itself becomes a small part of that, I think, or that's the intent. Yeah, it's more supportive.
I would definitely echo that. I mean, our staff of 20 in Honduras, that is their whole purpose and goal in between our medical teams. They are all about education. And if without the education, you're only pushing pills, that's not going to change anything. So we have really concentrated a lot of time and effort on continuing that education to support the communities and really help them to better the situation that they're in.
Well, thank you very much, everybody. And I'm looking at the clock. I would love to keep talking with you, but want to be respectful of people's time. And so that'll probably be our last question. Quick shout out to Ben Erker, and thank you very much for putting that information up there. We're looking forward to continuing this conversation on our community of practice, which we put into the chat box as well. There's obviously a lot of work still to be done, but we have confidence that, shown through this network and the way that this work has been developed, that it's not only possible, but there's so much more to be learned through your great networks as well. So we look forward to continuing the conversation and making this even more collaborative in its next iterations. Thank you so much for spending your time with us today, and thank you to all of the panelists. We look forward to continued high-quality PQMD webinars through our community practice. Take care and have a great day, everyone.
Bye, everyone. Thank you.
All right, thank you.
Bye.